But that being said, I do actually need to share my screen with you guys. So, post tools, share screen. Okay, can you guys see my PowerPoint?
No, not yet.
Okay, hang on. Hmm, I want to open allow participant. I was actually trying to do this on my like my desktop, and it told me that it had to have an update to it, so I couldn't do it on there either. Hang on just a second. Who can share? Advanced share. I want to. I'm gonna have to Google it. Give me just a second. Sorry, people. Okay, you guys should be able to see it now. Can you see it?
Yeah.
Cool. Okay. All right. So I'm gonna kind of like pull this over. Actually, I'm just gonna minimize this and then I'll talk. Okay. So I'm gonna go through slide by slide. You guys, what I kind of want, my goal is that you guys have reviewed the material and we'll talk about piece by piece and I'll kind of stop at your questions. So we'll go by objective, just like we would kind of in lecture. Objective one asks you to discuss the anatomy and physiology of the cardiovascular system. So what I really need for you guys for this objective is just to have an understanding of, and I know we've been over this in um, semester one. I also know that we've been over this in you guys have probably been over in anatomy and physiology, but please understand the structures of the heart. So we have our right atrium, our right ventricle, and then we have our left atrium and left ventricle. We have our pulmonary artery and our pulmonary vein that moves blood from the heart to the lungs and then from the lungs back to the heart. Okay. So have an understanding of that and those structures. Also understand that each one of these areas between, so between an atrium and a ventricle, and between a ventricle and the artery. All of these are open and closed by a valve. It's really important to understand that when we talk about the disease processes that affect all these things. So, um, we also have, so also I know we've gone over this in semester one as well, but if you don't understand the blood flow through the heart, please take the time to refresh yourself on it. Oh, sorry. Um, So make sure that you understand blood is coming into the heart from the superior and inferior vena cava into that right atrium, okay? Travels through the valve into the right ventricle, up through the pulmonary artery to the lungs, where our gas exchange occurs, back through the pulmonary vein into the right, or sorry, to the left atrium, to the left ventricle, where it's pumped out of the body through the aorta, okay? So it's really important if we're going to talk about all of these disease processes to know the structures and how the blood actually flows through the heart. Okay. Um, that's really the majority of kind of what I wanted to say about anatomy and physiology. That's the main things. The rest of this, I just kind of want you to guys to review. Just really a review. You kind of already know the majority of it. Obviously, our heart carries blood for us. It's our oxygen carrying capacity. Our oxygen holds, or our, sorry, our blood holds onto those oxygen molecules. Um, and it travels throughout our body to perfuse the rest of our tissues and our organs. So those are the bigger things. Does anybody have any questions about that particular objective in the anatomy and physiology piece of the heart? If not, we'll keep going. Okay. Objective two. So this talks about perform a focused assessment for a patient with cardiovascular disease. What I want you guys to pick up from this objective is when you're doing an assessment that's focused on a cardiovascular assessment, like what are the primary things you should be looking for that are outside of normal limits, right? So I've got a couple of different slides on here. Um, if we're taking in a health history, one of the things we need to consider is if they have a history of cardiac conditions. That can look different depending on the age of the patient and the patient population we're talking about. But always take that into consideration. Like, does the patient have hypertension? If they're a child, do they have a history of congenital heart defects? Like, there's a lot of different factors that we need to take into health history. Another big piece of that is medication. Okay. So always especially for people with cardiac history, we need to get a very comprehensive medication list. We need to make sure that we know all the things they're taking. If we're talking about the physical exam, okay, within normal limits, obviously, our blood pressure is stable, our heart rate is stable, our respiratory rate is stable. And I know I talked about this in the screen recording. For patients with cardiac conditions, you might see high or low blood pressure depending on the cause of the cardiac problem. Okay. We may see a high or a low heart rate depending on the cause of that cardiac problem. Most of the time, our respiratory rate is going to be high because our body's trying to compensate for the lack of oxygen associated with our heart not working like it's supposed to. Um, what you're typically going to see, though, so if we're talking about a physical assessment and just the way that somebody appears when they come in and they have a cardiac issue, most of the time, if we think our heart's pumping blood to our body, to our tissues. If something isn't working right, we're not getting perfusion. We're not getting oxygen, right? So typically, these people are usually pale, they're diaphoretic. Sometimes, even if it's really significant, they might even exhibit like cyanosis around the lips or even, in the peripheral, like vasculature in their fingers and toes. So we want to assess for all of those things. Typically speaking, you can usually tell if somebody comes in and they're like, I think I'm having a heart attack, and they really are. They're usually really pale, really sweaty. They just really don't look good. Um, so those are some things we would want to assess for and make sure that we're including in our physical assessment. Other important pieces, we always want to do our obviously our auscultation of our heart sounds, right? We would want to listen for anything abnormal. We're likely going to want to hook them up to a monitor and check their heart rate and rhythm. Okay, we're doing EKG. And then we'll talk about EKGs here in just a minute. But another big piece of the cardiovascular assessment is the peripheral vascular system. So our heart is pushing that blood out with the intent of pushing it out to the rest of our body. So what we would hope to see is um, we are going to hope to see those peripheral pulses that are normal, right, when we feel them. So our radial pulses, our pedal pulses. If something is altered with the cardiac system, right, a lot of times what we might see is absence of pulses or really weak pulses, or you may even see bounding pulses depending on the actual cardiac problem. Another thing you're going to see is poor capillary refill, right? So we're not getting perfusion to the rest of our body. We're not getting perfusion to our tissues. Okay, so capillary refill is likely to be impaired too. I'm just gonna open this and make sure nobody else is needing in here. Hang on just a second. Okay. Oop. All right. All right. Does anybody have any questions about that particular objective? One and two are pretty straightforward. Just understanding the anatomy and physiology and understanding how to do a focused cardiac assessment. Okay, so let's talk about objective three. So this asks you about what labs and diagnostics um, for patients with suspected, or interpret labs and diagnostics for patients with suspected or actual cardiovascular disease. So what kind of labs are we going to see on these kind of people? Okay. Some of the main things you're going to see, and almost always what you're going to see, is if somebody comes in and they're like, I have chest pain, they're concerned that they might have a cardiac issue, they're likely going to draw a troponin. Okay. Um, So that troponin is a marker that tells us if there's ever been any cardiac muscle damage to the heart muscle itself. So we'll talk about the pathophys of some of these diseases in a minute, but basically, if we have a blockage in an artery, so let's go back up here to our picture, okay? And let's look. So you see the anatomy of this heart. So our heart has its own vascular system, right? We have these nice vessels that blood actually has to flow through to perfuse the heart muscle itself, okay? If something gets blocked in these, that means that blood can't flow to the heart muscle. Um, so when that happens, or if that happens, the tissue, just like it would in the peripheral system, the tissue past the point of that blockage is going to die. You're going to have injury to the muscle because it's not getting any blood flow. So if we kind of go back down here and liken that, what the troponin is measuring is if there's ever been any damage to those muscles because of a lack of blood flow. The troponin is very common. A creatinine kinase is also a common, you'll hear it referred to as a CK. It's also a common lab. Myoglobin, not as common unless you're in a really specific cardiac area, but I did throw it in here. Um, Other labs that you're likely to see. Okay, so if we think about some of the pathophys behind why we develop cardiac problems, our cholesterol level is really important, and we'll talk about atherosclerosis here in just a second. But it's important to know what our cholesterol levels are because that can tell us um, how much cholesterol is actually living in our bloodstream. And that cholesterol has the potential to build up inside the vessel wall and create plaque. Okay, so it's important to know those pieces. What I do want you guys to have just a generalized understanding of is like what's a reference value. I didn't stick them in here, but you just need to know like what a normal reference and what would be a very out of range reference for each of these. Others that you're going to likely see, a BNP. I know I talked about this in the screen recording, but a BNP is often how they differentiate if the patient has a cardiac problem or if they have a fluid and electrolyte problem or a respiratory problem. So, lots of times what'll happen, and we'll talk through some pathophys of these diseases, but if our heart isn't working, then we often have fluid backing up into the lungs, okay, which can present like a respiratory problem, right? So if we have fluid in the lungs, that patient's going to be short of breath, their oxygen's not going to be very good most of the time. What differentiates and what tells us if it's cardiac in nature or if it's respiratory in nature is usually this lab right here, this BNP level. If this is elevated, it usually will tell us that it's usually a cardiac issue, and it's usually a good indicator that that patient is in heart failure. So that's a pretty common lab that they'll often do if they're concerned about that. Some of the others they'll do a CRP. We won't talk too much about these, but if they're concerned the patient is at increased risk of heart disease, they might look at the CRP level. CBC's electrolytes, we kind of talked about that in our last lecture. Really important to know what all those electrolytes are because they can impact cardiac function. Okay, other labs, an EKG. So at the beginning of semester 3, you guys are going to learn how to actually do EKGs. If you get the opportunity to do it in clinical, I want you to go do it. I know some of you guys are in and out of the ERs and stuff like that. So if you ever get the opportunity to go put the EKG leads on, go do it. I think it's a good thing to learn, but that's a good diagnostic tool for cardiac problems. It'll tell us if that patient's having an arrhythmia, if they're having an electrical problem. It can indicate if they're having a heart attack. So it's a very important diagnostic. Um, an echocardiogram is going to tell us an echocardiogram is an ultrasound of the heart itself. It's going to tell us like what the structures look like, what the function looks like. Usually, it's a really good indicator of what they'll do is they'll measure what they call an ejection fraction, and if they're looking at an echocardiogram, it'll tell you how much blood is actually coming out of the left ventricle of the heart. Okay, and that's super important because that left ventricle is responsible for the total volume that actually pumps out to the rest of our body. Okay, so if that left ventricle is impaired, um, and we're not getting perfusion like we should. So echocardiogram is one of the primary diagnostics they'll do for that. Other things you might see, stress tests. I know yesterday, I think Kim was in the cath lab. So I don't know if anybody else has had the opportunity to be in there for clinical, but cardiac catheterization is another diagnostic that they might do, where they'll go in and they might go in through the patient's radial artery, and they'll actually go in and look at the heart structure itself, and they'll shoot contrast dye into that heart. And what they're doing is they're looking for blockages. They're also measuring for pressures. They're looking to see if that patient needs like a heart stent or if there's complete blockages. Basically, it gives them a visual of the heart to say like if there's anything that needs fixed or if there's anything they can do to fix a problem. Um, Okay, so one last slide on this objective. Other things you might see, which we won't talk too much about these, they have specific CTs for heart scans, MRIs too, not as common as these we just talked about. Sometimes a chest X-ray can tell us like if there's fluid around the heart or if the heart's enlarged. Um, Patients who they're concerned about, like if they have an arrhythmia that they're living with, they might put them on what they call a Holter monitor, and that would tell them if they're like living with like a an arrhythmia that only happens every so often. They have to wear this for like 24 hours. Same kind of thing with an event recorder. It would kind of record if there was a adverse like arrhythmia or something. So are there any questions on the labs and diagnostics under that objective? Is that pretty clear? Okay. All right. So let's talk about objective four. Four and five are where a lot of the information, especially four, where a lot of the information really comes from. Okay. Um, so objective four, we're going to talk about all of these different pathophys of these diseases. Okay. What I need you guys to know are each of these pieces in this objective. So what's the pathophys? And I broke it down pretty good. The pathophys, the etiology, the priority, nursing interventions, labs, diagnostics, pharmacologic treatment, and management of these disorders. Okay. Some of them aren't quite as involved as others, but we're going to kind of briefly go over them. I do not remember what video this is. Hang on just a minute. I can't ever remember where they're at in my lecture. Okay, I'm going to leave that video up and I'll talk about it here in just a second. But this link gives you a video of basically a whole breakdown of heart failure, what it is, what it means when it's compensated versus decompensated. I highly recommend that you watch that video to help you understand heart failure. So we're going to talk about it, and I want you to watch it on your own. I'm not going to pull it up during the recording, but it is a very good video to help clarify those points and what each piece is. But let's talk a little bit about heart failure. So heart failure is basically when the heart can't pump sufficiently. Okay, so there's some reason that it can't pump. There's various reasons that cause, so the etiology would be the cause, right? Coronary artery disease, so that plaque buildup inside the vessels, hypertension, cardiomyopathy. There's various causes, okay? There's also different types. So there's left-sided, right-sided, and high output. What we're going to talk about are the left-sided and right-sided, okay? So we need to know if we go back to that original anatomy on the heart, the left side of the heart is our left ventricle pumping blood out. The right side is where our right atrium and right ventricle live. So we're going to talk about the difference and what happens if one or the other side fails. All right. Okay. So I put this in here because I wanted you guys to kind of see a true breakdown of what these patients kind of look like. And this is really what they look like in real life most of the time. So if we go back to the function of our heart, I'm going to go back and pull up my nice anatomy up here. Okay. That left side of the heart, okay, we have our, if we're thinking about the blood flow through the heart, we come in through the right atrium, we go to the right ventricle, we come up through the pulmonary artery into the lungs, and we come back through the pulmonary vein into the left atria, into the left ventricle. In left-sided heart failure, this side of the heart is not working, okay? So something over here is not pumping well. There's something going on with this side of the heart. So what happens when this can't pump or this can't squeeze, or there's something causing it to be ineffective, is that blood is going to go backwards, okay? So if it can't pump out like it's supposed to, it's going to go backwards. So the structure immediately before the left side of the heart is the left pulmonary vein, which backs up into the lung. Okay. So blood on left-sided heart failure is going to back up into the lungs. So on these types of patients, what you're likely to see is people who are struggling to breathe because there's fluid in the lungs. There's an overflow of that volume, that blood volume hanging out in the lung spaces. Coughing. When you listen to these people, they're likely to sound really, really coarse, like crackly, like when you hear a patient in fluid overload breathing, like you can almost hear fluid moving when they in their breath sounds. Um, Usually they're really restless if they're not getting there. So what's also happening is inside that lung space, it's filled up with blood volume and fluid. Gas exchange isn't able to occur because it's taking up the space where gas exchange occurs. So we're not able to get enough oxygen or gas exchange to perfuse our body. So usually they're really short of breath. Oftentimes their oxygen level is really low if they come in. So this is really what these people look like. They usually just don't have any ability to like if they're in significant enough heart failure, they don't have any ability. They can barely breathe a lot of times when they're just trying to talk. Okay. So that's the left side. So let's talk about the right side. This is kind of a blurry picture. So let's go back up here to our structure. Okay. So our right side, our blood's coming in from our inferior and superior vena cava into that right atrium, through into that right ventricle. So what happens in right-sided heart failure? So if we think about it, we got to flip our thought process here. But if the right side can't pump, it can never pump blood. It can't ever really get enough blood into this pulmonary artery to get to the lung in the first place, okay? So something's happening on the right side. And so again, if it can't pump through the structure, it's going to back up to the structure that's immediately before it. So what's before that right atrium is the superior and inferior vena cava, which leads out to the venous system of the body. Okay, so the right side's not working. Blood that can't get through this right side very well is going to back up into the venous system of the body. So if we look at this picture again, and we look at right-sided heart failure, we've got patients who are basically the blood volume is getting pushed back into the venous system of the body. These people usually have, so think about where your blood is pooling and sitting. It's usually sitting in that venous system. So these people are likely to have really distended neck veins. Lots of times it's putting extra pressure on like these organ systems and like the venous system of those organs. So you'll see what they call ascites, which is like kind of some fluid enlargement around the liver. They usually have really large, like bellies, kind of like protruded abdomens. It usually does cause some like organ enlargement just because the pressure on the venous system is so high. These people are usually one of the biggest assessment pieces on these people is what we call a dependent edema. So these people, when you go assess them and you're looking at, their peripheral vasculature and their skin, they're likely to have pitting edema. Depending on the severity of the heart failure, their edema is probably really like you're gonna poke their leg and it's gonna leave an indent in it. So it'd be like maybe +3, +4 pitting edema. Um, so this is when I talk about heart failure, what I really want you to understand concept-wise is the difference between the two and where that blood is going depending on the type of heart failure. So left side is always going to back up into the lungs, right side it's going to back up into the body. Okay. Let's talk a little bit about these. So if we have any of these types of patients right here, our interventions always are to monitor their respiratory status. If they need oxygen, we're going to give oxygen. We're going to try and elevate that head of bed to offset any like additional like fluid impact on the lungs. So we talked in our fluid and electrolyte lecture about restricting fluids, right? These are the types of patients we often have to restrict fluids on, okay? Because they're holding on to fluid. The heart can't pump like it's supposed to. That fluid's backed up into the venous system. Um, Lots of times these people end up with like low sodium levels because like we're hanging on to fluid. It depends on kind of your patient pathophys, but sometimes we have to restrict fluid. We have to restrict sodium because I talked about this in the screen recording, but water follows salt, right? So if we have a lot of sodium intake, what that's going to cause is even more fluid buildup in that vasculature because our water or our fluid is trying to dilute that salt, so it causes even more edema. Okay. These patients, we always want to monitor daily weights. We want to see how much weight they're gaining. It's really, really important to know that on these types of people. We're going to give whatever medications are prescribed to these people. Labs and diagnostics that are all important are kind of listed here. Some of the primary pharmacological treatments are going to be diuretics. Okay. We're trying to pull fluid off of that vasculature. We're trying to pull fluid off the lung space. We're trying to get as much fluid out of where it's not supposed to be. Okay. Um, I think those are the bigger points I wanted to make on heart failure. Is there any questions about heart failure? Is anybody confused? Okay. Let's go on to I'm going to briefly touch on some of these. I do want you guys to review some of these on your own. I'm not going to go into depth on like valvular heart disease. Basically, what that is when we talked about those anatomy of the heart. So if we're looking at our structures here, if you talk about the anatomy of the heart, valvular heart disease is a disease of some portion or one or more of the valves that basically shut between the atrium and the ventricle or between the ventricle and the pulmonary artery or vein. Okay. So something's happened to cause a disease in that valve. So that valve, what it's supposed to do between uh, atrium to ventricle, if we talk about that lub and that dub, what we're hearing is the valve close. So lub dub is valve opening and closure. Okay. Um, Closure always. So left side, right side, lub dub. Um, When there's valve disease, though, something might happen to that valve that causes it to like what they call prolapse, or maybe it has fallen into the ventricle too much, or it's so there's other issues that that can happen with it. Okay, but basically, if it's not working correctly, or if there's some issue, oh, we have to be done in 10 minutes. Um, if there's some issue with the valve itself, what can often happen is that blood, there's no closure here, so the blood can backflow. Okay, so it's really important. Valves are very important to make sure that blood isn't flowing backwards. Um, so if we're looking at valvular heart disease, one of the primary things I want you guys to pick up on is um, making sure that these types of patients are always like if they ever have a valve replacement, they're always going to be on blood thinners or some kind of anticoagulant to make sure that blood doesn't pool in that new valve space. Okay, so it's really, really important to make sure that those patients adhere to their medication regimen. I don't want to talk too much about effective endocarditis or pericarditis. I want you guys to review those. Rheumatic carditis. The only thing I'll note here is that typically the etiology on this is actually strep throat that has not been treated. So if a patient has strep throat and they go for a long time, they don't get antibiotics, they don't get treated, it can actually turn into what we call rheumatic carditis. So in the old days, people actually did die from this because they didn't have antibiotics. But basically, what would happen is that strep infection would actually lead to inflammation of the heart due to the rheumatic fever caused by strep throat. So it's actually an interesting pathophys. But so we always want to make sure that we're treating strep throat like we should. Okay, let's talk a little bit about these two atherosclerosis and arteriosclerosis. I want to bring up this picture. In atherosclerosis, so a normal artery, we have no plaque buildup. We have healthy blood flow through that artery. There's nothing causing any kind of like uh, complication to the flow of blood. If we are patients who are at risk for, they have atherosclerosis, really high cholesterol, again, the patients in Oklahoma like to eat a lot of like high fat foods. We see a lot of people with these really high plaque, lots of atherosclerosis. So what happens is when we have a lot of fat in our diet or we have some genetic predisposition to this, we're seeing plaque buildup inside those arteries. Okay. As it continues to build, what can happen is it can completely close if it gets too significant, or some of this plaque can also just break off and travel, which both are very bad. Okay, so it can cause a lot of different disease processes. So that's why atherosclerosis has to be managed very carefully. One of the other pieces, I know I talked about this a minute ago that I want to bring up. So let's go back to our vasculature of the heart. What causes cardiac or what causes like myocardial infarction is that plaque buildup in these vessels that perfuse the heart. Okay, so if our heart has to have its own blood supply to the organ to itself. So if something happens and so, we go a long time, we're living with plaque in these arteries and we never know about it. And then all of a sudden, either we become completely closed off or plaque dislodges and clogs one of these. Whatever's past the point of that artery to that blood flow, right, is going to not get perfused. So if, say, that this descending artery right here doesn't get perfusion past it and it is our blood supply to our left ventricle, then our left ventricle can't pump, right? So, and then if our left ventricle can't pump, we don't have any cardiac output at all. So it's really important. That's why it's super important to manage atherosclerosis. Um, okay. Any questions on atherosclerosis? We've talked a little bit about hypertension. I know I talked about that in the screen recording. I don't want to touch too much on that. Mostly, we know that our pharmacologic treatment, it's really important to manage it. The lifestyle changes are important. Pharmacological treatment's very important. Um, I do want to talk about this just a little. In peripheral artery disease, what we're seeing is like maybe somebody who had atherosclerosis, um, in a peripheral artery. So say like in the lower leg, or usually it's in the legs. So say they have peripheral, like a plaque buildup in an artery in the leg, and the blood can no longer flow past that point, right? So blood can't flow past the point of that um, buildup of plaque anymore. We can't get perfusion past that very well, okay? Especially if it's narrowed or if it's completely occluded. We'll talk about that in just a second. But if it's narrowed out, we're not getting any perfusion. So we're not getting perfusion to the tissues around it. We're not getting perfusion past it. So a lot of times what can happen is that patients develop these arterial ulcers whenever they're not getting perfusion past like a plaque buildup in a peripheral artery. Um, if it becomes completely occluded, this is what can happen. Okay. So complete occlusion means that that artery is completely blocked. There is no blood flow. So if you're looking at a peripheral vascular assessment and you're worried that the patient might have an arterial occlusion, you're not going to feel any kind of peripheral pulse in that extremity, right? There's going to be no blood flow past the point of that occlusion. Um, if that does happen and they can't go in with some kind of like interventional radiology and break that plaque up or get a stent in that, they're looking at like this is called a fasciotomy where they actually opened up that space to try and relieve that pressure. But if you leave it blocked and the blood can't flow past it, blood is just pooling into that tissue space. It can actually cause compartment syndrome. And what can actually happen is our tissue dies because that so our tissues are a closed space. So our tissue actually ends up necrosing and dying off because there's no way to get perfusion past that much pressure. Um, so I think that that's kind of an interesting thing. I did talk a little bit about this in the screen recording. Um, Arterial aneurysms, um, so outpouchings in that vasculature along basically the main points of our arterial system. What can happen is like they can weaken, those walls can weaken and they can burst. And so if that happens, the patients usually they're at risk for bleeding out inside. The only other thing I want to point out on here on this part is venous insufficiency. So basically, when we're talking about venous insufficiency, the venous system isn't returning blood from the lower extremity back up to the cardiac system very effectively. So blood is pooling into those vessel spaces. So when that happens, we see like the progression of this happen where we get these like spider veins and varicose veins. For people who are like up on their feet all day or static standing, they're at higher risk for this. One of our primary interventions is just let's try and elevate the legs. We need to be mindful of how we can kind of manage this. The biggest difference between venous insufficiency and arterial insufficiency is you're never going to have a good pulse with an arterial insufficiency, whereas in venous insufficiency, your pulse isn't affected because all that your arterial system's not the problem, right? So you have a pulse, you just don't have venous return. We only have a couple of minutes before this thing's going to shut off, I think. So if I'm going to open it to any questions that you guys have. I want you to study your meds. Um, I think I went over them really good in the screen recording, so I would just kind of watch that particular piece. The biggest thing I really wanted to touch on was heart failure. So hopefully that's pretty clear and makes sense. There's not anything about any of these medications that I did not touch on in the screen recording. So if you just want to watch that portion, I think that would be helpful. But let me know what questions you have so I can answer them. Anything. Okay. If you guys don't have questions, I am good with you guys going ahead and hopping off of here. But like I said, if there's something that comes up or something you don't understand, please let me know. I did record this, so I'll go ahead and post it, okay? Otherwise, I hope the rest of you guys have a good day.
Thank you. You too.
You're welcome. I'll see you guys on Monday.